Okay. Wishing everyone salam sejahtera and a very good evening. It's almost good night now, but I do understand that in our busy schedules, some of us may be just returning from work. Some of us would be closing our clinics for the day. And instead of resting, um, I'm really terharu lah. I'm really proud to see that about 100, close to 200 participants are here on a Thursday night to listen to our talk. Thank you for that response. Yeah, it's always for a webinar, right? It's nice to see participation in terms of emojis and all that. So thank you so much. My name is Dr. Sivabala Selvaratnam. I am the chair of the Women's Health Committee as well as the honorary deputy secretary for MMA. And this is our second episode of Let's Talk About series. So the first episode on the Let's Talk About series was launched in January of 2025 um, with the topic on heavy menstrual bleeding. And at the end of the topic, we requested what would the participants like to hear about in our next episode. So there was a lot of input. But then again, when we sat and analyzed, we thought that, you know what, let's go with this topic of infertility. And curiously, a few of my colleagues raised it. The moderator is from MMA Perak. The speaker is also from Perak. How come we got Perlis branch? So just bear with me before I introduce the speaker. Women's Health Committee is one of the newest committees in what do you call that, in the MMA, and we thought that instead of webinar fatigue that some of our members have expressed, why not collaborate with various branches? So episode one uh, was an inaugural episode with MMA Penang branch, and I would like to give a huge shout out to members from the Perlis branch for facilitating episode two, which is subfertility and the primary healthcare physician. So a big shout out to MMA Perlis, which is the smallest branch in the MMA, but getting to be very, very active. And without further ado, I would like to introduce the speaker, right? Um, he's very passionate about the topic, but before you all run away, right? I'm very certain that once Dr. Tam Seong Wai starts speaking, everyone is going to be super glued on. But for those who stay right to the end, I will give you an idea of what's coming up with regards to the Women's Health Committee, which also translates to CPD points. So for some of us, we depend on these webinars and the activities to garner our CPD points to renew our annual practicing certificate. So please stay on till the end. Uh, Housekeeping announcement, your Q&A box is open. So all methods of communication is through the Q&A chat box. Please keep your questions coming and we'll do our best to answer each and every one of them. So if I have not addressed anything in the housekeeping announcements, please feel free to ask in the Q&A as well. Stay on to the very end, and upcoming events as well as CPD points would be announced later in the talk. So without further ado, I would like to introduce the esteemed speaker for today evening. It is none other than my consultant, obstetrician and gynecologist at Hospital Raja Permaisuri Bainun, Ipoh, Perak. His name is Dr. Tam Seong Wai. He's also the head of reproductive medicine in the Ministry of Health and the head of the Malaysian Reproductive Medicine Training Program. So basically, suffice to say, he's Taiko Besar inside KKM, the head of reproductive medicine. Uh, and if I were to go through his CV, we'll all be sitting here for the next 20 minutes because it runs in a few pages long. Uh, I believe I've done justice to giving him that honor and the title that he is reproductive medicine for the pathway into practicing in Malaysia as a reproductive medicine specialist at the moment. So without further ado, Dr. Tong Seong Wai, the floor is yours.
Thank you, Dr. Sivabala, for the kind words and your super introduction. I'm just a normal government servant. I serve the government. And of course, it's very nice for all of you to be attending this webinar today. Yeah. So I hope I'll be able to tell everyone who took their time, your precious time. Yeah. Today is an evening, you'll be having dinner and all that. So your precious time to explain to you in simple terms what the general healthcare practitioner can do when you encounter patients who are coming to you with fertility issues. Yeah. So, okay, so I will start my talk. Yeah. Okay. So this is the single most unimportant slide, introduction of my name. Okay. So we are going to talk about subfertility and the primary healthcare physician. Okay, let's have a look and see what does WHO define subfertility as. Well, it is defined as a disease affecting the male or the female reproductive system, and there is a failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. Now, this subfertility is classified into two types. Basically, the first one is the primary, where the couple or the lady has never ever conceived before, not a single pregnancy before. The other one is the secondary subfertility, which means the lady has actually conceived before, but it doesn't mean that she has a child. It could have been an ectopic pregnancy. It could have been a miscarriage. Yeah. So secondary infertility means the lady has gotten pregnant before. Now, why is fertility or subfertility so important? Because it's in the headlines now. If you listen to our YB Nancy Shukri, the Minister for Women and Health, Women and Children in Malaysia, she keeps on talking about total fertility rate, and Malaysia is dropping like mad. Our TFR is dropping like a brick. So 1 in 8 couple will have difficulty for having a child. And the diagnosis can be both male or female, combined, or it can be unexplained. We just don't know where the fault is. If a couple were to try to get a baby every month that they try, they have sex regularly, they do it all the time, you only have a 20% chance of getting pregnant. So we got to know when to seek help, to let the public know that there is a time limit, you need to seek help. And definitely the primary health care physician, like all of you out there, plays a major role. And people like us in a tertiary center, we only handle the other end of it. So the prime, to me, the people who are actually going to increase our fertility rate in Malaysia will be the primary healthcare physician. So the treatment, there are so many types of treatment, but everything depends on the investigation and the history that we take from the couple. Yeah. And mind you, less than 3% of people require IVF. Yeah. It's just that nowadays people want it fast and people want the higher success rate. That's why they turn to IVF. But if we look at it logically, only less than 3% of couples coming for fertility treatment actually require IVF. So now let's look at the problems of infertility, a little bit of knowledge. Yeah. As I told you, 1 in 8 couples have problem conceiving or sustaining a pregnancy until term. And Women, mind you, are born with all the eggs they will ever have in their whole lifetime. The women are born with 1 million eggs in each ovary when they come out from the mother's womb. And when they achieve puberty, they only have 200,000 eggs left in each ovary. So over the years, you will lose all your eggs. And every cycle, roughly 1,000 little tiny eggs are recruited to grow and mature into an oocyte. So on average, a lady will ovulate about 400 times in her whole lifetime. So don't wait too long. But men are different from women. They do go slow when the age comes. The sperm count drops, but in women, it drops drastically. So women are the key people that we should encourage to reproduce at an earlier age, because when they grow older, it will be that much more difficult. Yeah. Okay. Now, how long should it take to get pregnant? If you look at 100 couples trying naturally to conceive, only 20% will conceive in a month. And at the end of a year, 85% will conceive. But I will tell you this, nowadays, the world is changing. We are getting married older. We are having a lot of issues with our life. And that's why our total fertility rate is dropping. And when should we see a doctor? If, let's say, the lady is less than 35 years old, well, take your own sweet time. You have regular sex. Wait for up to a year. If you can't conceive, go and see your friendly neighborhood general practitioner. Let them work you out. But if you are more than 35, please do not waste time. You can try naturally only for 6 months. If at the end of 6 months you do not get pregnant, better go quickly to see the doctor, because you are running out of time. Yeah. And if you are over 40, please, 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 you get married, try it for 1, 2 months, you can't conceive, just go and see somebody. So let's look at when the couple gets married, they can't conceive. You blame me, I blame you, and the in-laws blame each other. So whose fault is it? If you look at it, 30% of subfertility is male. The other 30% is female. And there's a combination where both have issues. So that gives you 90%. And the other 10%, we investigate, we look at them, we examine them. There's nothing wrong. And these are the unexplained. And we are absolutely worried about the unexplained, because if we don't know the reason, how are we going to treat them? So male fertility issues, very simple. Can he produce sperm? Can he deliver the sperm? Whereas in female, is she producing the eggs? That means, is she ovulating? Is she delivering the eggs? That means, is the fallopian tubes intact? Is implantation of the fertilized ovum occurring? Is the uterus okay? Are the hormones okay? Is her fertility endocrine system working? So these are the issues we should look at. Now, as I mentioned earlier, our life has changed. In fact, we are changing for the worse. Infertility, which is unable to get pregnant at all, and subfertility is increasing. Why is it increasing? Because we are chasing after material things. We are chasing after money. We are chasing after career. We are forgetting that we are getting older. Increase in incidence of sexually transmitted disease. We are becoming more freer in our interaction. And women are delaying childbearing because they want a career. So On top of all this, we should also realize that our world is getting super polluted. And a lot of fertility experts worldwide predict that mankind will be extinct in the very near future, and we will be extinct because of the male problem. Because the seminal fluid analysis of man is becoming worse and worse over the years. Our sperm count is dropping, our motility of the sperm is dropping, and we have lots of abnormal sperms. The reason is we are drinking, we are eating, we are inhaling pollution. One fine day, we might actually be looking after antenatal patients of this age group, yeah? The matured mother. Now, let's look at the total fertility rate trend. Initially, in the 1990s to 1995, the global fertility rate is 3. That means every woman has 3 offspring. Now, when we reach 2010, it was 2.5, and it is predicted worldwide in 2045, we are 2.2, and in 2095, it is 2. Now, we should also know that the replacement is 2.1, yeah? We cannot have 2, because if we have 2, we are only replacing. We need to grow. And if you say that, oh, this is good, 2.5, 2.2, this is good, we are still above the 2.1, well, you should know that these numbers are only coming from a certain area on planet Earth, that is the African continent and the Asian continent, whereas the rest of the world, the fertility rate is dropping, and Malaysia is going into fertility recession. As you can see, last year was the worst, where we hit 1.7. Yeah, that was the absolute worst. But apparently this year, our YB Nancy Shukri said, we have gone back up to 1.8, but this is still no good because we are below replacement. We are an aging population. So it's predicted that in the next couple of years, there will be more old folks than young people. And these young people cannot drive the economy, and they cannot bring what you call money and progress to the country. So, well, today's talk, the highlight is make babies. Infertility risk factors. Let's look at what are the risk factors. Past cancers. And as you know, pollution, bad food is making our body bad. And we are getting a lot of cancers. In fact, the end of last year, I saw 3 young boys, yeah, between the age of 16 to 23, young males. They're coming with testicular cancer. Can you imagine? 2 of them school going. One is working as a Grab driver or something like that. And they've been diagnosed with testicular cancer. So that is the end of their fertility. Yeah. So what can we do? We freeze their sperm, ask them to masturbate, freeze the sperm. So cancers. And also I have a couple of oocyte freezing where we freeze the eggs because these ladies have got ovarian cancer. These ladies have got other types of cancers, lymphomas, leukemias. They undergo chemotherapy that will whack off the ovaries. So these young ladies, I will stimulate, I freeze the eggs first, so that even if the ovaries do not recover later on in life, when they get married, I just need some sperm from their husband and I fertilize the oocyte, I can still make babies. Yeah. So our world is actually turning upside down. Now, the risk factor, if your periods are on the dot regular, you can tell that in September, you want to go to Maldives and swim in the sea, but in the middle of September, you will be having your menses. That tells us your periods are regular. It'll be a higher chance of you getting pregnant faster, easier. And if you have irregular periods, that means there is something very wrong with your endocrine system with regards to the female hormones. So if you have problems with menses, you may not ovulate. If you are smoking and drinking just by inhaling our beautiful Malaysian air and drinking our super clean Malaysian water, eating our super clean and super nice Malaysian food, we are actually taking in a lot of pollutants. So now you want to add on with smoking and drinking, please go ahead. My advice is take care of your health. Money is not everything. At the end of the day, your health and your family is everything. Now, we are becoming more open in society, and this has led us to have an increase in STDs. Yeah, I have got young ladies coming in with both tubes blocked. You do a laparoscopy, she has got pelvic inflammatory disease. So just we got to be a little bit more what you call conservative, yeah. And if you are unable to stop yourself from having free sex, fine, condom, yeah, use a condom. And please get married earlier, have sex more frequent, and get babies faster. Try and get a baby before you are 35. And Malaysians, you know, whether the economy is good or bad, we eat. When the economy is bad, we are so depressed, we eat. When the economy is good because we have money, we eat. So either way, we are dead. And we are the ones who, you go to the supermarket, they park the car right at the front door. Right? You go to the market, you park so near because you don't want to walk so tired, so sweaty. Please, the next time, park your car at the furthest end of the parking lot and walk. Enjoy walking, yeah? So you can eat as much as you want, but please exercise and remove what you have eaten, yeah? Enjoy your food and enjoy your exercise. Okay, now what are the signs and symptoms that one may have that tells us that you have some fertility issue? In females, they are often asymptomatic, but some come with heavy or painful menses. Now, when you have this, I can assure you, you have some issue with your endocrine system. You may have some issue with your uterus. You may be having adenomyosis, endometriosis, you may be having fibroids, or you may be PCOS. Yeah. If you have irregular or absent periods, of course, we know you don't have menses, you won't have eggs. So this usually happens in PCOS ladies, which is basically an endocrine problem. Yeah. Now, what are the signs? The signs are abnormal hormone levels. We know that the FSH LH ratio should be at least 1.5:1. Now, in PCOS, there is a reversal. So the LH is much higher than the FSH. And if you were to check the male hormone levels, yeah, the androgen, free androgen index, you will find that they have very high levels of androgen. That's why they're very masculine. And because of that, they have hirsutism and they don't ovulate. Now, blocked tubes. When you have recurrent vaginal discharge, and when the discharge is heavy, you get slight pain or even cramps in your lower abdomen, which may be associated with feeling unwell, low-grade fever, chills, rigor. This can tell you that maybe you are having pelvic inflammatory disease, yeah? And STDs. STDs will lead to blocked fallopian tubes and pelvic inflammatory disease. Now, what about males? Males generally do not give you symptoms. And if they ever present to you, they will say, I have erectile dysfunction. Okay, my brother doesn't listen to me. It has a mind of its own. When I want, it doesn't give. When I don't want, also doesn't give. That means literally never give. Or you can have guys coming to you with ejaculatory issues. In fact, I get a lot of men now coming and telling me that, yes, I can have sex, but I end too fast. Doctor, please help me. So what I tell them is, that's a different issue. You come to me trying to get pregnant, as long as you can have sex and you are able to ejaculate into the vagina, it doesn't matter whether you go in once, you thrust once and twice and you ejaculate, or a million times before you ejaculate is fine, as long as you deliver the sperm inside. Now, once you get a child, you come back to me. I'll teach you how to last forever. They are actually, it's basically counseling, yeah? So if you have premature ejaculation, that's an issue. Sometimes some men come and tell me just by touching the penis to the labia, they ejaculate. So that's an issue. Yeah. And if you have testicular pain, please go see your friendly neighborhood physician. Testicular cancer, I have seen so many. It's frightening. Signs of male infertility. Well, you have abnormal hormone levels. Your testosterone level is very low. You're always feeling tired. You have muscle wasting. When we check your sperm, your seminal fluid, the sperm count is low or is immotile or a lot of abnormal sperms. And when we do testicular biopsy, it comes back as testicular failure. Yeah. So there are a lot of issues. Now, what are the reasons that you are not getting pregnant? It could be because you're not ovulating. Your sperm is too little, too slow, and too abnormal. Or because the partners are very old, especially important when it's a female. Or the fallopian tube is blocked. Usually when I talk to the layperson, they will say, fallopian tube blocked? How? Why? Then I say, for example, you want to go to Brinchang. You need to check whether the Tapa Road is okay or not. And you also need to check the Simpang Pulai Road. Now, if one of the roads is not okay, you can still go up. But if both the roads are not okay, you will never reach Tanah Rata. So I will need to use a helicopter to bring you to Tanah Rata, which is IVF. So fallopian tube checking is very important. Endometriosis, if you have painful period, please check your tubes. Check your endometriosis. Yeah. Sometimes they come with cysts in the ovary, chocolate cysts. Sometimes they come with dilated tubes. Some of them, they have severe dysmenorrhea. And when you do a vaginal examination, the whole of the back of the uterus is so tender. Yeah. And when you scan, you can see in adenomyosis, the uterus is so big. And of course, nowadays, a lot of young people are falling sick, yeah, medical problems. They have hyperthyroidism, diabetes, hypertension. So the world is not getting better. It's getting worse. So the causes for female, you can have ovulation problems, which is hormonal imbalance, PCOS, obesity, and low ovarian reserve. It's frightening to note that nowadays so many young ladies are coming, and when we actually check their FSH level, yeah, the FSH level is very high. That means the ovary is failing. When we do a scan, the ovary has no follicles. In fact, I have a dentist who is only 29 years old when she first came and saw me. She is menopausal. I have to start her on HRT. So she's been on HRT for the past 2 years. That is how frightening it is. And the reason, I got no idea. She's very well, she's active, she eats well, healthy lifestyle. It's just that she's having premature ovarian failure. So there's nothing we can do, yeah? Tubal blockage in cases of endometriosis and STDs. And of course, there are a small group of women with uterine problems. They have got septums, they have got biconjugate uterus, there's a septum in the uterus, or the uterus is love-shaped. Some of them, I jokingly tell fellow colleagues, not to the patient, but to fellow colleagues and medical students or to the nurses, how to explain diadelphys, okay? Which is you have two uteruses, two cervices, and a nice septum in the vagina. It is a buy one, free one. That means God gave you two of everything. And this is a big problem. Yeah? It's a major problem because it's an anatomical problem. How can we treat it? Well, that's for another episode on another night. So causes of male infertility, sperm problems. We must understand that the testicle is hanging outside the body because God put the testicle outside the body. Nobody ever thought about it, right? But if you look at the cat, the dog, the cow, the goat, the horse, the monkey, the orangutan, every male creature on planet Earth, the testicle hangs outside. Why? Because it functions at a temperature of 35 to 36 degrees, and our body is 37, too hot. So when you have a fever, the testicle will dangle far away from the body. When it is cold, the testicle will be pulled up to maintain the temperature. So if you have varicocele, where you have dilated varicosities, yeah, dilated veins in your scrotum, it's going to heat up your testicle and it's going to give you a hell of a lot of sperm problems, yeah. Sometimes sorry, we get kicked by people, we get beaten by dogs because the testis is hanging outside, or we fall down and hurt the testicle. Diabetes. Now, diabetes is on the rise now, and it gives rise to erectile dysfunction. And we also know that diabetes actually makes our sperm production, spermatogenesis, very bad. Sexually transmitted disease, of course, we know. They screw up our spermatogenesis. And obesity. Our body is so full of estrogen instead of androgen, yeah? Fatty tissue stores estrogen, which is not good for spermatogenesis. So a lot of hormonal disorders. And of course, a very, very small group has got the Y chromosome problems. Yeah. So for another day, we will talk about genetic disorders in male, but just for general knowledge, yeah, the Y chromosome is affected in some males, so they will never become fathers. Too bad. So the causes of infertility, the most common, hormonal imbalance. The other causes are PCOS, endometriosis, scarred ovaries. That is why when we talk about scarred ovaries, we always say, please do not do any surgery. If you find endometriosis, if you find ovarian cysts, if you find things wrong with the uterus, with the ovaries, please do not simply go in and cut, because the ovary is like an apple. Yeah, I say it looks like an apple because the baby eggs are found in the outer layer, yeah, the cortex of the ovary. And our hormone production is in the medulla or in the center of the ovary. And this endometriosis grows on the surface of the ovary. So when you go in and cut the endometriosis, it's something like you're cutting away the brown part, the bruised part of the apple. If you cut too much because you don't know how much you're cutting, at the end of the day, you are actually throwing away a lot of the apple, leaving the seeds behind. So the cortex is cut away. You are actually decreasing the chance of the lady conceiving because the baby eggs are all cut away. So try not to do any surgery for endometriosis, especially if it affects the ovary. If you want to go in and do, you do it one time only, and do it at the best time, and immediately after surgery, get her pregnant. Don't simply go in endometriosis. This year, after 2 years, endometriosis, you keep cutting the ovary. At the end of the day, there's nothing left. Yeah. So, well, we have seen a lot of that. Yeah. Okay. Now, fertility and age. Age is the single most important factor for a lady. Please, 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 for all of us who have daughters. I've got a daughter who's 26. I'm very scared. She got no boyfriend. I asked her, you want boyfriend? And she said, Papa, shut up. So I'm worried. So age, very important. Women, the number of eggs, it drops and drops and drops. So if it drops, I'm not too worried. But as it drops, the quality of the oocyte also drops. What do I tell my patients? I tell my patients, you should come earlier because all the good eggs will come out first. They are super strong. They're super ready to become human beings. So they will ovulate faster. Now, at the age of 35, 40, what is left behind? The eggs that are very lethargic, very tired, the eggs that are not normal, the eggs that do not respond, the eggs that has problems are left behind. So when you super ovulate them, you do certain techniques to make the oocyte come out. You give them tablets, you give them injection. Now these eggs are of poor quality, and that's why nature has it as age increases, the chance of you conceiving by yourself drops. Not only because the number of eggs are less, but the quality is less. That's why you get a lot of abnormal babies when you are matured, yeah? So that will tell you fertility age relationship. Now let's look at the fertility rates by age. If you are 20, touch only pregnant. If you are 30s, touch a few times, sometimes, most of the time, you get pregnant. Fertility in the 40s, you do it until your husband is, how do you say? In Chinese, they call it ao pak po. You do it until your husband is literally getting a heart attack, you still find it very difficult to get pregnant, yeah? Mainly because you are not going to ovulate that much. You may have your menses, but those are empty menstrual cycles without ovulation. And you may need other techniques to try and conceive. Sorry. Okay, so if you look at female egg count by age, you can see how it drops, yeah? If you look at egg quality, it's the same thing. So please don't wait forever. There's a Malay song, jangan tunggu lama-lama. Nanti lama-lama semua diambil orang. So male fertility. Features of men's fertility, sperm production, a little bit of basics. It occurs in the testicle. Of course, it cannot occur anywhere else, only in the testicle. And it takes 74 days for one sperm to be produced. I've got patients coming to me, doctor, I'm a chain smoker. I don't smoke chain, but I smoke a lot of cigarette, 1 to 2 packets a day. So tomorrow I need to do my IUI. So I stop today. Tomorrow I can do my IUI. My sperm should be okay. So I say, my dear sir, you have to stop smoking 74 days before we can see the effect. It's not stop today. Tomorrow you can give me the sperm and it works. Okay. So I guess all of us have to tell our patients, it takes about 3 months. You stop smoking 3 months. Then your sperm may have a chance to improve. And sperm transport. We can take sperm from your testis. Okay, we call it surgical sperm retrieval, but the sperm is not as good as the sperm that you ejaculate out because there's a process. It must go through the seminal gland, the prostate gland, and they add a bit of ketchup, add a bit of what you call the oyster sauce, add a bit of salt, pepper. Then the sperm coming out is super good. But if you just go in and take the salmon out right from the fridge without adding all these condiments and all these savory things inside, it's not going to be good. That's why ejaculated sperm is the best. So sperm transport can be a problem. And sperm function. You can get sperm, but the sperm must be able to function. At the head of the sperm, there is an acrosome. It's like a cap. I tell my patients there's a cap on the sperm's head. When this cap touches the egg, it makes the shell of the egg open and the sperm goes in. Once the sperm goes in, the force field around the egg quickly shuts, so no other sperm come in. So it must have proper function. And all the good sperms have to fight for the egg, yeah? And if you have a bad tail, 2 tails, no tail, curly tail, big head, small head, it's not going to work. So that's why these are the features of men's fertility. Now, a healthy sperm. The count should be around 15 million minimum per ml. Okay. The motility must be at least 40%, either slow and fast, rapid or slow sperm, doesn't matter, as long as you can swim forward because the sperm need to go and look for the egg. And the shape, the morphology must be at least 4% normal. Okay. Now, with age, like I told you just now, we always say that female menopause, but men no pause. Well, sorry lah, men. Men also pause. Male fertility declines with age, but more slowly than females. We function better. The most fertile age for a man is before he turns 40. Yeah? This is when he goes swimming in Selat Malacca, the Indonesian lady gets pregnant. That is how strong he is before 40. After 40, well, we also take a downturn. So sperm motility count and shape decreases by 50% after you are 50. So men, please try and get your child ASAP. Okay, now look at this beautiful Malay lady. How are we going to diagnose? Okay, we are going into, when a couple comes, how are we going to tackle this couple? So history, very important. Age, yeah, like I told you. Have you ever got pregnant before? If she says, I have got pregnant before, wow, that's a good point. She has a good chance because she's able to conceive previously. Has she ever taken contraception? That means she is fertile. But that also means what type of contraception you should ask. If she takes injectable, well, injectable like Depo, some of them have after effect where it is a little bit more difficult to go back to her normal. Yeah. So you must ask, what type of contraception did you use? You must ask for menstrual cycle details, whether it's regular or not, how is the flow, any pain, any dysmenorrhea, any dyspareunia, pain having sex. When do you have intercourse and how frequent? Now, the sperm is alive and able to stay alive in the female genitalia for 48 hours, that I assure you. Sometimes, occasionally, for 72 hours. So how frequent should they be having sex? At least 2 to 3 times a week, because we do not know when the lady is going to ovulate. So I always tell the husband, if you want to tackle your future wife, but you do not know when she is going to come off work, what do? You stay in front of her office without going anywhere for 2 to 3 days. You will get her. So duration of infertility, if the infertility is 1 or 2 years, fine, not too worrying. But if she tells you it's already 9 years now and I've seen 4 doctors, my God, this is going to be a problem. Yeah, the longer the duration of infertility, the more serious the problem is. Then you ask for history of abnormal cervical smear, pelvic surgery, sexually transmitted diseases, past medical history, whether she had any cancer and cancer treatment. Look at the thyroid. The other thing I didn't write inside here, I forgot to write is, ask her whether she has galactorrhea. Galactorrhea means she has milk coming out from her nipple, because this will tell you she has hyperprolactinemia. And you know when the prolactin is high, the lady will not ovulate. She will not even have menses. That's how the lactating amenorrhea method works. You know, after you deliver, you give exclusive breastfeeding, so the prolactin is high. That is a method of contraception. So I forgot to write, yeah, prolactin, yeah, hyperprolactinemia, galactorrhea. Ask her whether she has got galactorrhea. So drug history. Ask whether she's on any drugs, or I mean medication. Recreational drugs is a no-no. Prescribed drugs, example, antidepressant. Antidepressants will increase the prolactin a little, yeah? Antipsychotics can also disturb your ovulation function. Then lifestyle. It's work, 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 no play means no baby. And she is stressed, she will not ovulate. Her endocrine system is upside down. If you drink too much, no good, because it affects the liver. And you know the liver metabolizes a lot of things in the body. So it also metabolizes and maintains your hormones. Smoking, no good. Exercise. Do you exercise or are you sedentary? Okay, we have finished with the man. Now let's look at this beautiful, the woman. Let's look at this beautiful man. Ask for past medical history of severe illnesses, whether this man had any major problems with his health. ask about mumps. The way I ask about mumps is, I ask ada bengkak di bengkak cantik di muka yang kita sapu nila. Because in Asian countries, we put this blue thing, you know, the nila on top of it. So mumps can affect the testis. This virus will go and attack the testis and make you sterile. And in ladies who have mumps, it can go to your ovary, cause inflammation, and make you sterile too. So mumps, especially in boys, please ask. Past history of sexually transmitted diseases, and ask whether you had any surgery done on your testes. Orchidopexy, you have got undescended testes, or the testis is inside your tummy or in the inguinal canal where they need to do surgery and pull down your testes. So it will be too hot, too long for the testicle. Remember, right? 35, 36 degrees. Just by wearing hot, tight underwear, you are screwing it. So now the testis is up in the body, which is too hot. Yeah. So if you have surgery, any previous children and drug history, either prescribed or recreational. Now, next, what to examine? Of course, when you look at the woman, check her weight. Do a pelvic examination, yeah, a gentle one. See whether she got any aches and pains anywhere. See whether you can feel any mass in the adnexa. And you look for hirsutism. See whether she has a lot of pimples or not. See whether she's got mustache, beard. See whether she's hairy or not, yeah. And men, again, look at the weight, check the scrotum. Please drop his pants, feel his testes. The testes roughly should be as big as the size of his thumb. Okay, not thumb, but thumb, his thumb, his thumb. And it must feel like your nose. It shouldn't be soft. Okay? If it is soft, no good. If it is hard like your forehead, no good. It must feel like your nose. And please check for varicocele. How do you check for varicocele? You put your hand on top of the scrotum and you roll it. If you have got varicocele, you'll feel like there's a bag of worms inside there. And when you ask him to strain, you can really see all those dilated veins in his scrotum. So also look for secondary sexual characteristics. Example, you got Klinefelter syndrome, you know, where he's a male, but the male looks so young. The body doesn't have secondary sexual characteristics. So please look for pubic hair, for muscle and things like that, yeah? Okay, a bit touching on fertility tests. You can tell your patients to go back and do some home fertility tests. Do the OPK, ovulation prediction kit, yeah? If you get 2 lines, do like mad. Okay, ask them to go back and have sex like mad. They can do this at home. Or you can measure your basal body temperature. You can check your cervical fluid. Put your finger in your cervix, and if you can pull that cervical mucus very long without it breaking, please go have sex. Anyway, today is Thursday night, malam Jumaat. And of course, do the pap smear, do the AMH, anti-Mullerian hormone, that will tell us your ovarian reserve, how many eggs you have left there. Your day 3 FSH, your estrogen. Then please do an ultrasound, look at the ovary, look at the uterus. The hysteroscopy and biopsy, we leave it out. Genetic testing, also leave it out. Now, if you look at this simple hand-drawn diagram, first, male infertility, you check the sperm, whether that fellow is putting enough bullets inside or not. Number 2, look at the ovarian reserve. You check the FSH. If the FSH is very high, the early FSH between the 1st to the 5th day, so usually we ask for day 2, day 3. If it is very high, that means the ovarian reserve is low. You can take the AMH, anti-Mullerian hormone. If it is very high, that means very good reserve. Very low reserve. The advantage of AMH is you can take it anytime. Yeah, it is not related to daytime, nighttime, after food, before food, having menses, no menses, not related. At any time you just take, it's fine. It'll tell you the reserve. And do an ultrasound. Just look at the ovary, look at the small, small little black dots. Usually around day 2 to day 5, if you find a lot of black dots there, good, there's a lot of egg. No black dot, you are dead. Very minimal eggs, yeah? So this is a general diagram. Now, what investigation? Having taken a complete history and examination, number 1, the woman, and then number 2, the man. I always say no woman, no man, but a lot of people say no man, no woman, but I think it's woman first, yeah? Do an FBC. Check if there is any problem. Rubella. Day 21 progesterone that will tell you whether she is ovulating or not. If it is very low, she's not ovulating. So what do you have to do? Give her some tablets, give her some medication to make her ovulate, and then monitor. We'll come to it later, yeah, the treatment part. Then you do a day 1 to day 3 FSH LH. So the ratio, as I told you, 1.5 is to 1. It will tell you the ovarian reserve just by looking at the FSH level. It can also tell you PCOS when there is a reversal of the FSH-LH ratio. Check for sexually transmitted infections. Use prolactin. Yeah, do a serum prolactin, see whether it's high or not. Do thyroid function test because hyperthyroid, hypothyroid, both too little and too much is no good. And of course, you can always order a HSG, which will tell you whether the uterus is normal or not and whether the tubes are patent or not. In the man, very simple. Ask him, can you have sex? If he say yes, fine. If he say no, then tackle that problem. If he say yes, check the sperm and advise him, do not wear tight underwear. And the way I advise is, you look at your grandfather. Your grandfather doesn't wear underwear. How many children does he have? Many. You look at your father. He wears underwear, right? But he wears the olden underwear, the triangle one, the crocodile white color one, which is very loose. Got how many children? Got a few, but less than the grandfather. What do you wear? I wear tight spandex underwear. On top of that, I wear bicycle pumps. Then I wear my tight jeans. How many children you got? Zero. Because you're pulling your testicles up and it's too hot. And what's your favorite pastime? Ride bicycle. Squeeze my testes together and in the hot sun. No good. How do you relax? I go to the sauna. I sit in a Tambun hot spring. You are actually half boiling your testicle. Please, lah. We are not in Hokkaido. Okay, so general advice, very important. Don't smoke. Don't drink. Social drinking is fine. Don't do drugs. If you check the sperm and the sperm is zero, no sperm, please do a FSH on the husband. If the FSH is very high, above 14, that means we are looking at testicular failure. There's nothing you can do. Okay, now, treatment part, yeah? What can the primary healthcare physician do? Number 1, please do not treat them separately. Treat them as a couple. Yeah, couple-centered management. And it must be holistic. Don't just treat saying, yeah, your wife got PCOS, that's why cannot get pregnant. No, you must also look at the man, tell him healthy lifestyle, all that, yeah? Tell them to stop smoking, stop drinking, stop doing drugs. Advice regarding ideal weight. The BMI of the woman, chubby, plump, okay, but not fat, not obese, yeah? So slightly overweight is fine. Check rubella status, check cervical cytology, and please start on folic acid. Some of them, a lot of my patients say, ayo, when I wanted baby, I take folic acid, but I take folic acid also, I don't get pregnant and no egg come out. I say, please, folic acid is for your future baby, for neural tube defect, for the brain and the spinal cord, not to make you pregnant. Then they say, oh, I see. Then they start taking, yeah? So folic acid is for other things. And advise regular intercourse. If you guys have intercourse 1 to 2 times a month, how do you expect me to get you pregnant, right? So tell them, I would like to help you, but you have to help yourself. Give them advice. 10% of my patients who come to see me for fertility issues, I talk to them. The first visit, sitting down, talking to them as a new couple takes me 30 to 45 minutes where we trash out everything. And when they go back, 10% of them come back without completing all the tests that I wrote for them. I say, doctor, no need. Thank you so much. We got pregnant already. So it works, just talk to them. Offer support and encouragement where investigations are negative. That means they may not be doing it right, yeah? It's unexplained infertility. And please refer in a timely manner. If you feel that you have tried, don't refer immediately. Do all the investigations after the history and then treat a bit. If you think that, oh, cannot, I have done my best, but it's not happening, then you refer. Don't wait until the lady is 40 years old, then you refer, yeah? Because I always believe in, I have a second last slide. I'll tell you, you can call me at any time, yeah? Call me at any time. I don't mind. I don't mind sharing information, sharing advice and all that, yeah? So refer in a timely fashion. So next, when are you going to refer? You refer early if the woman is more than 35 because we are running out of time. If she has got very bad, she doesn't have menses at all, or she has one spot and then that's it. So refer earlier. If she has got previous abdominal or pelvic surgery, something very bad. If she had got previous PID or sexually transmitted disease like this is a fallopian tube. You can see how dilated it is, yeah? That's pelvic inflammatory disease. Refer. Abnormal pelvic scan. You put a scan there and you see Ultraman inside. Okay, please refer quick. Previous genital pathology or urogenital surgery in men. Yes, please refer. If the man has got some trauma, which some surgery was done, I tell you there will be something very bad inside. Previous STD, varicocele. If you examine the genitalia and the genitalia is abnormal. If you have got very significant systemic illness, not only refer to people like me, please refer to physician, to surgeon, to whatever, yeah, to the ID, because we need a what you call multidisciplinary approach to tackle the problem. Now, this is a picture of the varicocele, yeah. Now, yes, this part is very interesting. What treatment can we offer as a primary healthcare physician? Number one, please tell them it's not about treatment, it's about a healthy lifestyle. It's about KKM suku separuh. So tell them if you like carbs, take complex carbs. Take more protein, healthy fats, water. You can go for vitamins and minerals. You can go for supplements. Please exercise at least 20 minutes a day. Don't overdo it. Nobody asking you to be an ultra marathon runner. We are asking for cycling, brisk walking, Tabata, yoga, things like that. Yeah, sweat it. Alternative therapy, please. A lot of us are under a lot of psychological and mental stress. Please go for meditation. Yoga is absolutely good. And acupuncture, yes. I even tell my IVF patients, go for acupuncture. It may help you at least by calming you down. Yeah. So by doing all this, you may be able to have a balanced hormone level. Take good nutrition, optimal weight, stress relief, healthy libido. I tell you, if you exercise, you will say, "Ayo, after exercise, so tired, how to have sex?" No way. You go exercise, you will come back. That night, you become a tiger. In Malay, a tiger is called hari harimau. I tell you, you go, yeah, guys, go and exercise. You come back, you see. In the evening, play badminton. Badminton. In the night, come back, become a harimau and mind badminton. Okay, now female, how do you treat? First of all, again, folic acid, any dosage will do, yeah? 400 to 500 microgram a day because it's marketed either as 400 or 500 is enough. It's 10 times above normal. So guidance to the fertile window. The fertile window is basically 3 to 5 days only. Yeah? It's usually between day 12 to day 16. Yeah. So you just tell them, monitor your mucus, do your ovulation prediction kit, which is the LH kit, basal body temperature, and then you have sex when there are two lines, when the mucus is very long, your basal body temperature rise little bit, have sex, keep on doing, yeah? In the case of end ovulatory cycles, you don't produce egg. Well, you can give them some medication so that they can, they can produce one, maximum two big follicles, yeah? Don't go for 3 or 4 because we do not want multiple pregnancy, please. And when they come to us, you know, it's so complicated when you have multiple pregnancy, higher risk of hypertension, diabetes, miscarriage, preterm labor, all those, yeah? So what you do is you give them some tablets, you monitor once the follicles are big enough, that is 18 to 20 millimeter, then which you do ultrasound, yeah? You can scan and you watch the growth of the follicle. Once they reach this size, the matured size, give them a jab of HCG, 10,000 units. So subcutaneous, just give them a jab in the belly and tell them after 36 hours, go and sing the song all night long for 3 nights. If you can't 3 nights in a row, then you do alternate nights for 5 nights. So do it for 5 days. Yeah, 3 to 5 days is fantastic. Okay, now what are the drugs you can use? I think very common knowledge. A lot of people use clomiphene citrate. That is the turun-temurun that people use. The second one is aromatase inhibitor, example letrozole. And of course, some use injectable, which is the FSH, gonadotrophin. Yeah? Now, for those who like clomiphene citrate, it is administered orally. The dose is 50 to 150 milligram a day. Yeah, you start with 50, try this cycle, doesn't work, let her rest 1 or 2 cycles, try again at 100, still no follicle, rest 2-3 months, come back 150. If at 150 still doesn't work, it's not going to work. Okay, so but of course, when you are giving this tablet, you must also look holistically. Tell the lady to lose weight, exercise, all those. So it depends, the dosage depends on obesity, metabolic profile, and previous response. So you give it from day 2 to day 5 or day 3 to day 6. Yeah. 2, 3, 4, 5, 6. Day 2 to day 6, sorry. Day 2 to day 6 or day 3 to day 7. Give it for 5 days. The drawback of clomiphene citrate. Okay. Clomiphene citrate is basically an anti-estrogen. So when you take this tablet, this anti-estrogen will make the FSH level in your brain go up, follicle stimulating hormone. So what does it do? It stimulates the follicle, but it is an anti-estrogen on your uterus. The endometrium becomes thin. So do not use it too frequent, yeah? Because even if the egg comes out, how can the egg, the embryo implant in concrete? Your endometrium is so thin, yeah? So then comes in the second type, letrozole. Letrozole is an aromatase inhibitor, 2.5 milligram per tablet. You can use again 1, 2 to 3 tablets. So what you do is, when you give this tablet, letrozole has no effect on endometrial thickness. It will help you to grow the egg, but it does not disturb your endometrium. Yeah, because we want the egg and the garden soil. The egg must be big and the garden soil must be thick, then it can implant. Yeah. So the advantage of letrozole over clomiphene citrate. And if all this doesn't work, well, you have given a few times this, then you use injectable, but go slow, yeah, 37.5 unit or max 75 unit, because you don't want too many eggs coming out. The other thing, a word of caution, clomiphene citrate, yeah, if you use it too frequently, it has been linked to ovarian cancer in future, yeah, so be a bit wary about clomiphene citrate. But it works very extremely well with PCO patients, yeah, clomiphene citrate. Okay, in the mail, what do you have to do? Please tell the gentleman, no matter what you do, when the partner is ovulating, please have sex. Now, don't say you're tired, cannot, no time. So you must talk to them. Yeah. Healthy lifestyle. Refrain from prolonged exposure of your testicles to hot tubs and saunas. Give them micronutrients or supplements like selenium, carnitine, Q10, vitamin E, zinc. Varicocele, if you find it, please refer for surgical treatment. And if you can, I believe even the primary healthcare physician can do IUI, you know. The next slide, I'll talk about IUI. IUI has a IUI swim up kit which you can buy from the companies. So IUI is in a primary care center can be considered if the sperm is a little bit low in count, a little bit slow in swimming. So you just need to prepare the sperm. Okay, this is IUI. So what do you do? Once you have got the follicle that is big enough, you have given the HCG, 36 hours later, I can't remember the company, but they have got this sperm swim up kit. They call the IUI kit, swim up kit, where you put the sperm like this. This is the bottle. You put it contains the media. You put the sperm into the bottle at the bottom, and you slant it at about 45 degrees. You wait for 1 hour. At the end of 1 hour, you just take the supernatant out and do the IUI with it. Okay, there are a few in the market. So if you are interested in that, please go search the market and you can try your IUI. Please, for God's sake, don't do neat sperm. There are some people out there who are, I know some doctors, they take the sperm, ask the husband to chop, produce the sperm, straight away take the sperm in the syringe and inject into the uterus. No, 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 no. Because the female can actually have an allergic reaction, you know. She can die from vasovagal, she can die from allergic reaction. And also you will introduce all the bacteria and all the bad things inside. That's why we need to prepare the sperm. There is a mucus plug in the cervix. This mucus plug actually prevents all the bad things from going into the uterus. That's why when the ladies go for scuba diving, go for swimming, their tummy don't bloat up. But you see the vagina is attached to the cervix. The cervix is attached to uterus. Uterus attached to the tube, and the tube is open to the tummy. So that means everything from the vagina can just swim into the tummy. But the truth is, no, there's a cervical mucus plug that blocks everything. So that's why when you check the mucus, when the mucus can be pulled very long, spin bucket, yeah? When it can be pulled very long, that means the mucus has softened, liquefied, so the sperm can actually swim through. At all other times when the patient is not fertile, the mucus is very thick, so the sperm is impenetrable. That's the function of the cervical mucus, yeah? So please don't do neat sperm IUI, yeah? It's dangerous. Okay, now, I know all of you out here, majority are primary healthcare physicians, and you all are superb. You are not like us. I only look at ONG and fertility. But you all look at the patient holistically, which is very good, yeah? So we should all look at the psychological effects on the fertility problem, yeah? So don't only look at trying to get them pregnant. Please look at their problems, psychological problems. So there is always stress within the relationship. Talk to them, give some TLC, and you give them some details where there might be fertility support groups. So people who experience fertility problems, you may or you should give some counseling. There are counselors in private hospital, there are counselors in hospital, yeah, because it's extremely stressful. I think all of you out there know that it is extremely stressful for the couple, especially the lady. So counseling may be required before, during, or after our treatment, yeah? So please don't forget this very important thing, the psychological aspect. And we are almost wrapping up. This is a very simple chart. A lady below 35, 12 months. A lady above 35, 6 months. Check the male. Semen analysis. Normal, look for other things in the female. Abnormal, go and see an andrologist. Female, check the day 21 progesterone. If it is high, ovulating, check for other things. Then, if got other problems, treat. If no problem, consider ovulation induction. Then if she doesn't, sorry, this is anovulatory. Sorry, I spoken wrongly. Progesterone level very low, anovulatory. She doesn't produce egg. Check the other causes of why she doesn't produce egg, like hypothyroidism, hyperprolactinemia, galactorrhea, FSH very high, primary ovarian failure, estrogen levels, then you treat. Okay, if she's ovulating, check the tube. When you check the tube, you will also know the uterus. If there's a problem, refer. Okay, I think at primary care level, if the tubes are blocked, there's nothing much that can be done. You will need to refer for IVF and things like that. Yeah. Okay, so this is a very simplified diagram. Okay, next. So this is all second last slide. To me, no one should suffer infertility alone. Yeah. We are in here for the long run. There are so many people out there who needs our help. If only we know how it hurts not to have a child. So we should always reach out and try and help. So please feel free to contact me for number one. If you have any queries, any assistance needed, please contact me. I'm always available. And I am very open to shared care. I'm a government doctor, but I have limited private practice in Sanford. So if you want to stimulate the patient at your center and come for treatment, that means you monitor the patient, you stimulate the patient, and then come to me for IUI or come to me for IVF. You do your part, I do my part. We can do shared care. I'm very open to it. Yeah. So you just let me know. If you want to refer to government, I'm more than happy. I can see them in government. If your patient wants you to refer to a private fella, well, I'm the fella also. I'm a hybrid fella. Nowadays we talk about hybrid, right? I'm both petrol and electric. So please contact me if you need any assistance. Yeah. Thank you. Thank you for your attention.
So, thank you so much for that, Dr. Tam. And yeah, from the emojis, I first of all, I would like to give a big shout out to all the participants. Lah. Believe it or not, we have got 465, 66 participants still online listening to you at close to 9:15 at night. And yeah, you can see all the love and emojis going up there. So yeah, well done. This is how we like it on a weekday, in spite our busy schedules. Now let's go to the Q&A, Dr. Tam. So
Yep, sure,
first
sure.
question, first question is, in patient with irregular cycles, such as say example PCOS, should we regulate the cycle before starting Clomid and Letrozole?
Yes, the answer is yes. Because if straight away you were to start them on ovulation induction with your medication, it's not going to work. Because her hormones are just too haywire. So my suggestion is you go for the what you call the general way, which is cut down, don't take sugar, cut down carbohydrate, exercise 20 minutes a day. That's that part. And then give her some OC pills to regulate her cycles. Yeah. And the recent paper said that last time we used to give Diane 35 to these ladies because it contains cypotyrone acetate, which is an anti-testosterone. But nowadays, recent papers say that you can give any OC pill. It works just as well. And also the other thing, start them on metformin. Preferably, I like metformin XR 750 milligram at night. Okay, this will bring down her androgens and normalize her hormones and also help her lose weight.
Thanks for that. I'm sure, I mean, very, very beneficial to primary health. Metformin XR, like you said, it's been in the market for so long and readily available. We can start that in primary care. Right. Next question. Is it a myth or fact having sex every day reduces a couple's chance of conceiving?
Yes, that's a standard question All couples ask me, especially the gentlemen. Now, I always give this scenario. You have got two bakeries next to each other. The first bakery, you go into the store, there is no bread because there's a long queue of people buying bread outside the shop, right? The other shop has got nobody buying the bread. So when you enter the storeroom, there's a lot of bread. Okay? Now, what is the taste of the bread in the shop where the storeroom is almost empty compared to the bread in the storeroom that has a lot because no customer? Of course, I'm going to the one with very low stock because the bread is so fresh and so good and so nice and so tasty. I wouldn't go to the shop where nobody goes and the stock is so stale and old. So basically, what I'm trying to tell you, if you have sex every day, your sperm count gonna drop like hell. Yes, agreed. But these are super new sperm. They are super fast. They are super normal. Okay? Now, if you keep your sperm for 5 days, you are going to ejaculate all the old men, all the pakcik, all the ape, all coming out, So it's basically a balance of both. Yeah. You can have sex every day if you can, but I tell you, it's major, major, major problem. You can't do it every day because the mood is not there. It becomes like, hey, come on, abang, cepat, cepat, cepat. Doesn't work like that. Man works differently. So you can try, but basically it will answer both ways. Yeah. You can have sex every day. You can have sex 3-4 days, but don't cross 5 days. Once you cross 5 days, your sperm is quite old. So the quality is not good.
Nice. Next question. For the patient with azoospermia, wife, everything is normal, the workup. What are choices of treatment the husband has got?
Okay. So first, look at the testes. Like I told you, it must feel like your nose, the size like your thumb. I mean his thumb, not your thumb, yeah. And if the testicle appears normal to you without varicocele, do a serum FSH. If the FSH level is normal, then the guy will need to find out whether his seminal tubes are blocked or not. Okay. If it is very high, forget it. Testicular failure, nothing you can do. If it is normal, then you may do a surgical sperm retrieval where we will put a small needle into the epididymis and we suck the sperm out. Okay. If we suck and then the sperm is not there, then we will do testicular biopsy. We cut a bit biopsy the testicular tissue and we look for sperm inside. We can still do, but basically it will be IVF. Sometimes we are lucky we get so much sperm from our epididymis aspirate that we can do IUI with it.
Right. So thanks for that. Yeah, you've got a thumbs up appreciating the answer. Next one, you touched on this. Has male infertility been increasing over the years? Any environmental factor responsible for that? You just gloss over.
Yes, definitely. As I told you, more and more papers, more and more
Mm.
research, and all the fertility conferences that people present in, the male sperm parameter is dropping, and it's very frightening. At the rate is dropping. Yeah, we will reach extinction very soon, and it's because of the male. It's basically because all the pollution that we are pouring out onto Earth. Just by breathing the air, you're killing already, and all this pollution, they will kill the fastest growing cell. We remember, right? Basic biology. The fastest growing fella is always affected by all the bad things. So the sperm is very fast. They replicate very fast. It's even faster than your RBC, because your blood takes longer. Your sperm is only 72, 74 days done.
I read somewhere on that, not to go back to grandfather stories, but I think they summed it up very nicely. Our grandfathers have had more sperm than all of
Yeah,
us.
yeah,
So, and
yeah,
you
yeah,
touched on that as well.
yeah.
Next question is, will there be any recordings available? Stay tuned. I'll address that at the end. Um, Next one, see high prolactin levels in PCOS patients. You touched on that. Should I refer the patient to the endocrinologist, order an MRI to investigate further? Otherwise, the patient has got no galactorrhea, so she's asymptomatic, but the levels show high prolactin. So how would you?
Okay, high prolactin, yeah. High prolactin, I think the person who asked, we should need to know how high is high, because above normal is considered high. But how high is high? If you were to ask me if the prolactin level is in the range of maybe 100 plus, I'm still okay with it. Okay, especially when she's asymptomatic. But of course, high prolactin, do not just sweep it under the carpet. The best, the gold standard, please investigate. And the person who put in the question is absolutely correct. Do an MRI of the brain. It might be a prolactinoma. Okay. Also ask regarding visual disturbance, yeah, because the optic chiasma is near the posterior pituitary. So take a good history, examine other systems, and then make the proper referral.
Perfect medical school recipe, Dr. Tom. History
Yes, yes,
examination management.
yes, yes.
Um, yep, another speaker went on to say, can we please get this recording? I'll speak about that later. Fantastic topic and 5 stars for Dr. Tom. So there you go. Um, Next question. Yep, lots more thumbs up and love coming up on the screen. How do we send? Okay, this is a conundrum for government KKM doctor. I can see it already, although they don't say that they're working in KKM. But the question goes like this: how do we send FSH or LH for those with irregular menses in the setting of a clinic kesihatan without a lab, where only specific blood taking day is available? So once a week they can take FSH/LH, but the rest of the time, and then we need to correlate that with the lady's menstrual cycle. So how does a clinic kesihatan doctor go about this?
Take the blood, keep it in the fridge.
Okay.
That's what we do in GH also, because we also pull the blood samples. Then when we get enough to run the cartridge, we run it, because the cartridge is expensive. So we pull it.
I'm sure most of those listening in today are from the private sector, if I'm not mistaken. But those in government have come across this very infamous two words, kekangan kewangan. Not klinik kesihatan, also KK, but kekangan kewangan. So this is how we do it lah, with limited resources. Another one of our, what do you call that, participants said, Dr. Tam, nice presentation. Hi, doctor, can you explain how to interpret semen analysis?
Okay, very simple. Sperm count, okay, the count per ml must be more than 15 million per ml. Motility, you only look at two parameters: rapid progressive and slow progressive. You add both these together, it must be at least 32%. Okay, they must move forward. They cannot be just motile, but like the pill kuda, they just shake the head, no point. They will have to swim forward and get the egg. And look at the morphology. Morphology must be 4% and above.
Right. Perfect. Hi, doctor. Lots of thumbs up and emojis there again. Is serum estrogen necessary?
Well, if the lady has got symptoms of estrogen problem, yes. But if you are in the private sector, I think you can take the package, they call it HP3 or something like that, which comes with your FSH, LH, prolactin, and your estrogen. Is much more cheaper than taking each one separately. Okay, but it's always good to have at least a baseline estrogen.
Thank you. How do we test for day 21 progesterone in a patient with irregular menses?
Fantastic, expecting that and got it. So what you do is, when the patient has irregular menses, I tell you, rest assured, she's not ovulating. But what you can do is, you do the other things. tell her about the healthy lifestyle. Don't ever give her tablet to induce the menses, because when you induce the menses, you're checking yourself. You're not checking her. So you regularize her menses by asking her to cut down her weight, watch her diet and all that, and see if she has menses or not. If she has menses, you can start. If after 3 months still no menses, then what you do, you give her 1 to 3 months of OC pill, stop it. After stopping it, then you test it. Because usually you can reset her ovaries for a short period of time after stopping the OC pill. That is the month you need to check.
Back to lifestyle modification there. Primary
Yes.
prevention. How
Yes.
do we decide to give clomid or letrozole?
The choice is yours. The choice is literally yours. You can use anything you want. But like I said, PCOS, clomiphene citrate seems to be slightly better.
And I think, as we all are very aware in medicine, it's not one size fits all. It's individualized care. I suppose, yeah, it's a informed choice. How does obesity cause infertility? I might have missed it, is the question.
Okay, obesity in either the male or the female, you will have problems because in the male, your sperm count will be bad. Your sperm motility, your sperm morphology, basically your sperm parameters will be horrible because all these fats store estrogen. That is one. Number two is when you are obese, your whole general health is bad. And when your whole general health is bad, your body cannot function properly. So spermatogenesis is affected. In a lady who is obese, the same thing, you got hyperestrogenism. So when your estrogen is very high, as I told you, clomid anti-estrogen, right? So drop the estrogen, you ovulate. So when your estrogen very high, you're not going to ovulate. Okay. And when you are fat, you got all the other things, diabetes and all that, your endocrine system also affected. So that's how obesity will cause infertility. Let's not talk about the physical aspect of having difficulty having sex. No such thing. It's basically what obesity does to our general health and our hormone system.
Thank you. And here you were speaking about shared care. Is someone who has been following your patients as well. And the question goes like this. Hi, Dr. Tam. I could see that few patients that you have seen for subfertility treatment where you started the patient on aspirin. Can I know the role of aspirin?
Okay, aspirin, very important. If the lady has got recurrent miscarriage, recurrent miscarriage is 3 consecutive, but to me, 3 is too much. Right now, the international bodies are looking at 2 consecutive. 2 consecutive miscarriages can be taken as possibility of recurrent miscarriage. So it could be because of autoimmune antibodies like antiphospholipid syndrome, ANA, anti-nuclear antibodies, increase C3, C4, all those things, which causes our blood to be very thick. So when these embryo implants, this tiny, tiny blood vessel, which can only allow one RBC to flow through, will get clogged up. So once it gets clogged up, the baby, the embryo doesn't get the blood, it will die. So in such cases, you give them baby aspirin or cardioprin, it may help. Okay. And also in people with hypertension, we will give low dose aspirin. And then the third thing is, if I have done embryo transfer, I have done once, it fails. I did twice, failed. The third time I'm going to give you cardioprin or 150 aspirin, because I want to increase or improve the blood flow to the implanting embryo.
Excellent. Um, Thank you. A question has been answered. Next one is a repeat question on irregular menses, and followed by another repeat question on on obesity. Uh, the next one is better to start on sonulate or other COCP. Doctor and patient choice. Would you say, Dr. Tom?
Yes, doctor and patient choice. Sonolute is short term to induce. OC pill will be better because it is something like you want to restart, your computer or you want to reboot your computer. I would always reboot and not restart.
Okay. Brilliant analogies all the way. And then, what is the cutoff point for level of AMH? And is it true that low AMH cannot even be put under IUI or IVF?
Okay, AMH. AMH, if we are talking about the government will not do IVF for a lady whose AMH is below 4 picomole. But in the private, my lowest AMH is 0.2 or 3, and I managed to get her pregnant with her own eggs. So the reason why the government put 4 picomole per liter is because we have the word that Dr. Siva used, kekangan kewangan. We cannot just throw money everywhere. So we would like to offer the people with the highest chance. So we need cutoff points. So unfortunately, below 4, we can't help in the government sector. But please do come over. We can do it in private. And the place I do is not too expensive.
Brilliant. And follow up on that, the next question from a different participant is there an age limit for IVF in government hospital setting?
Yes, 42 in the current year. If you are above 42, we can't help you. Again, the same thing, kekangan kewangan.
What about private, Dr. Tam? Would you encourage a 50-year-old then?
My oldest lady delivered 2 weeks ago. Tranti Hong Toy is 52. It's a miracle. Somehow, I don't know what happened. She got pregnant. And I delivered her 2 weeks ago.
Okay.
In private, the
Okay.
sky is the limit.
Having said that, I'm sure it comes with its own set of challenges when the maternal age is like that. And what are your thoughts? I mean, I'm straying off, but NIPT when the mother's age limit has, yeah,
Yes. I would suggest that any mother who is above 35, you can spend just a bit of money. Yeah? If you were to come to GH, yeah, Hospital Raja Permaisuri Bainun, you can get a full NIPT test, which is the complete one of all your chromosomes plus 60 most commonly occurring chromosomal anomaly for 900 ringgit. And this outside easily costs you 1,000 plus 2,000 something because we are doing it from the hospital. But of course, you pay. You pay. You pay online to the company. We will help by taking blood. It's something like we facilitate only. We are not doing it in GH.
another example of shared care, perhaps
Yes.
in a way, subsidized shared
Yes.
care.
Yeah.
Um, there's a fascinating question up next. When you don't have sex at all, is there risk for cancer due to this? I'm not sure whether she's speaking about the male or the female, but that's the question.
Okay. When you don't have sex at all, female, you are safe from cervical cancer. Okay. But you expose yourself to all other cancers. Okay. The male,
Okay.
when you don't have sex, you don't need to worry. You will have wet dreams. It will find its way out, and you're not going to have cancer. Don't worry.
All right. Next one. Good evening, doctor. How do we arrange for yeah? How do we arrange for day 21 progesterone? You have already answered that when in a KK setting, so you have taken that. Good evening, doctor. Can you brief a bit if I have a 40-year-old couple who's been trying more than a year to conceive their first child, is there any fast lane for them either in government or private sector?
Okay, if you have worked them up, then you can refer to us and we will take it from there. If you have not worked them up, please work them up first and then refer to us. It will be a fast lane. If you send to us, we will give a waiting time for the appointment to come and see us, and then they got to get worked up again. It will be slow. So you work them up first, win-win situation. You work them up, you refer to us if you think that they need our help.
Right. And how long do we have to prescribe OCP and metformin for?
Metformin, usually I will prescribe all the way until the baby comes out, until she delivers, because these PCO ladies will develop GDM. So the next question people will ask is, when you're on metformin, how can you do MGTT? Well, I tell my patient to continue doing the MGTT so it will come back as normal. That proves that the metformin is working. Okay,
Brilliant.
so she has to be on it.
Next one is again bread and butter for primary care physicians in private. Any good supplements that can improve quality of sperm or eggs?
Okay, sperm and egg, different thing, yeah? The sperm, you can go and prescribe. I think there are so many things out there, but the one I generally use is Profortil. I think every general practitioner out there knows, the primary healthcare physician knows Profortil, yeah? And for ladies, there's no way to improve your egg quality, but of course, go for a healthy lifestyle. Take vitamin D, coenzyme Q10, very important, antioxidants.
Right. Thank you, Dr. Tom. And then next one is how do we approach if a couple has got recurrent miscarriage, two consecutive miscarriages, for example? How do we approach this couple?
You got to investigate them. You look for gestational diabetes, you look for autoimmune diseases, okay? And the last of the spectrum will be look at the genetics. So you really got to send to a tertiary center for proper investigation.
And to be fair to Dr. Tam, this is off topic because his topic is subfertility. So in this case, they have no issues getting pregnant.
Yep.
They've gotten pregnant twice already, so it's not subfertility, but staying pregnant is the issue. So as he rightfully
Yes.
pointed out, they need to be referred on to tertiary care. The next comment here is from the chairman of the MMA Perlis branch himself, Dr. Satish Kumar, and he says, "Thank you, Dr. Siva, for moderating the session. I would like to thank MMA Perlis for giving us the platform and, more importantly, the more than 450 participants who are still online listening, and Dr. Tam, who is giving us his valuable time and still answering questions way past 9:37. So, Dr. Tam, a few more questions and then we wrap it up, if that's okay with you.
Yeah, sure,
And
sure.
for those who are staying, stay on, and I'll tell you about the recording and the upcoming events and more CPD points. So, thank you, Dr. Satish and MMA Perlis, for having us on board. Then we have, is the use of Dufaston works better compared to COCP to regulate menses?
COCP will work better because progesterone is a single agent. It's a progesterone only pill. So COCP should work better.
Next one is, does Profertil help with low sperm count or immotility of sperm?
It depends. We don't actually know what caused the sperm parameters to be abnormal in that gentleman. So we will give Profortil, and after 3 months, we will check again the seminal fluid analysis. That's why I always tell the gentleman, the first time you check your sperm and it comes back bad, don't be too sad. Wait a few weeks, we check again. Because sometimes you are not well. Yeah, you have fallen sick, there's some illness, subclinical illness, and your sperm parameter affected, you do a second test. If twice it comes back as bad, that means something is wrong. So you give Profortil for 3 months and then you have a look. I find that some people, the sperm count increases, but generally what I find is the motility and the morphology increases. Yeah, it's not much of the sperm count, but I have seen some with sperm count improving. So basically, it's the quality. Yeah.
Thank you, Dr. Tam. Okay, we have taken all the questions very slowly, clearly, and patiently, but this next question you have to be even more clear and even more slow because the question goes like this. How do we contact you for referral?
Oh, it's very simple. You can contact me either through the handphone. If you want to refer to the government, yeah, please take down this number 05 208 6162. This is a direct line onto the phone in my room in Hospital Ipoh. If you want to refer as a case of shared care where you do your part of the shared care and then you refer to me to continue the shared care, she get pregnant, she goes back to you can always contact me at 012-453-5072.
Can we have a replay of that, Dr. Tam, for those who missed it?
Okay, if you were to refer to me in Hospital Ipoh, most welcome to it. The contact number is 05-208-6162. If you were to refer to me for shared care, where you are managing the patient and then I just do the procedure for you and send the patient back to you, you can contact me at 012-453-5072. Please introduce yourself and where you're from if you're messaging me, because I have a habit not to answer when I don't know that number.
Too many
Thank you.
scam calls. I don't answer as well,
Yeah,
Dr. Tam.
yeah.
So, the next one, next question: is it true that COVID causing erectile dysfunction and reducing sperm quality and production? Does COVID do that?
Okay, this is hearsay. We do not know. But if you ask me, don't quote me, I think it is affecting the male fertility. It affected our fertility. And in the ladies, the COVID era showed that the vaccines actually created a bit of havoc on the menstrual cycle.
So, for those of y'all who want to get a book, your hands on a book, there's something called the COVID papers, which of course is evidence based, and there was again
Hmm.
controversial, but it's out there that the vaccines created havoc with regards to fertility as well, and it's touted as crime against humanity. Not my words; it's out there in the book. So if you want to get your hands on the COVID papers, I'm not the author, but feel free to have a read and know more about the disease as well as the treatment that went on. Next question is good talk, Dr. Tam. Investigation for women, we need to do separately. Day 1 to 3, FSH and LH, and day 21, progesterone. If we only want to take one of it for feasibility for our patient, what's the best day?
Day 21. I just
Okay,
need to know whether you're ovulating or not. You remember the algorithm I gave you? Clearly
right.
stated in the algorithm, no anovulatory, ovulate the patient. If you're ovulating, look for other reasons.
Again, a repeat question about women who are not menstruating, how to take it. You covered it, start the COCP, regulate the menses, healthy lifestyle, so on. Is it significant if agglutination presence in seminal fluid analysis?
Yes, it is significant because that means all your sperm, they are gays. They just play with each other and they don't want to disperse and look for the egg. So sometimes it is caused by infection, sometimes it is caused by abnormal seminal secretions. So we can actually analyze the sperm, do a culture sensitivity, things like that. Yeah. So we can find out what is the problem with the sperm. Why are they agglutinating with each other?
Next one is something we tackle, our nurses tackle in the hospital when they advise the patients. Can the male get the seminal fluid done at home and sent to clinic to be sent to the lab?
Okay, I will allow that, provided the bottle we gave to you is completely sterile. You keep it sterile. You collect it in your house in the appropriate manner, no using soap or anything. Just clean the penis with plain water, masturbate into the container, close it, switch off your car aircon, put the bottle either inside your wife's bra or put it in your pocket without the aircon, yeah, and reach the hospital within the hour, because drop in temperature, cold, kills the sperm. And if you keep it too long, they die. So if you are able to comply with this, fantastic, go ahead.
Kena apa? Uh, Kena adhere to quality control, I would take it. So kalau tak boleh
Yes.
adhere to quality control, tolong jangan buat di rumah ya.
Yes.
Right. You touched on this, but one of the participants would like to know if patient with low AMH 0.1, is it possible for her to have successful IVF
Please send the patient to me. Let me have a look at her because there are other things I need to explore.
as soon as possible? I would take it because
Yes,
already
yes,
low. Let's not waste time. Hi, Dr.
yes.
Tam. When do you need to do anti-Mullerian hormone tests?
Basically, I will do AMH if I'm looking at IVF. Apart from that, I will do the baseline because the AMH is very expensive, a few hundred ringgit. So only when I want multi-follicle stimulation, that means I want more than 2 follicles, will I look at the AMH.
Right. And a repeat question on Profertil again, you have covered it. And then a common question that we get from our speakers in these sessions, can we please get the slides from this webinar? Dr. Tam, are you okay with that?
Yeah, I'm fine. I'm
Would it be,
fine.
we
Yeah,
can
sure,
send
sure, sure,
the PDF version now.
sure, sure.
Uh, how to manage lean PCOS?
Lean PCOS, you need to give them metformin. That's all. They're already doing a good job. If you do an FSH-LH, their FSH-LH is almost normal and they may be ovulating. So they are already quite good. You just need to give them metformin so that the testosterone will come down a bit. The androgen, the free androgen will come down a bit.
Okay. What is the role of Clexane in a patient going through IVF?
I would say, well, I wouldn't give Clexane. IVF and Clexane, I wouldn't give. Not solely because of IVF, but I may give Clexane if you have recurrent miscarriages, if you have got antiphospholipid syndrome, if you have got SLE, if you have got the rheumatoid factor positive, things like that, hypercoagulable states, then I may give Clexane. But if you say, I want to give Clexane and I want to do for IVF, no, I don't think there's any guideline or any protocol to say that you do that.
Thank you for that. Thumbs up there already. How much is an IVF at your center, doctor? Is another question.
Okay, it can be 14,800 all in. That means the doctor's scanning charges, consultation, the full medication is buffet style, as much as you need. The egg pickup with sedation, the ICSI, we don't do IVF. Every single one we do ICSI. And even if you give me 10 eggs or 80 eggs, the price is the same. And we will put back one embryo, transfer, and we will freeze 5 extra embryos for you, all in for 14,800. And if you are above the age of 40, 42, I think, and if your AMH is very low, below 8, then it will go to 18,800 because of the amount of medication that we need. So it is, but general population is only about 14,800 all in, no hidden cost. It's a net cost.
Okay. Thank you so much for that, Dr. Tam. And then that's the okay. I'm going to questions are running on. So to be fair to Dr. Tam, he has stayed way past his time, way past the CPD point. I'm going to cut this off with the next 5 questions. Would that be okay with you? You've got at least 20, 30 down, but we'll cut it off at 5. Doctor, may I ask, is it advisable to do pre-implantation genetic testing prior to IVF? And in what situations would you do this test?
Before I answer that question, Dr. Siva, yeah, for all those kind people who are staying with me at 10 o'clock tonight, we are having a fertility hybrid course in August. Yeah, you look in the Facebook. We have hybrid. You can join online. You will get CPD points. Yeah, and it's not expensive. So you can hear more of these things there. Yeah, just join online. It is called the H-star, HRPB, fertility, hybrid cost. Okay, coming back to
And thank you for
PGT.
that, Dr. Tam. I think you've got a huge fan following here. They will be on board.
Thank you. So PGT, yeah. Now, if I have got a couple coming to me and they have had family with abnormal children or chromosomal problems proven to be present in the family, definitely I will do PGT for this couple before putting the embryo in because the risk is just too high. If this couple has had their own abnormal baby, I will do it this time. Okay, PGT. If this couple were to be thalassaemic carriers, both are thalassaemic carriers. Let's say beta thalassaemic trait with beta thalassaemic trait. I am going to do PGT for you because your risk is 25%. That means 1 out of 4 of your baby going to die of thalassemia. So that's a bit too high. Okay. And if you are above 35, I will offer you. If you're above 40, I will push you because the risk is high. Other than that, I won't do anything. And there is one last one, which sometimes I do. There are some couples coming with 2 girls or 2 boys, and they want a different gender. So I will do PGT. I will agree to do PGT, but I will not do sex selection. That means I do not kill babies. I will put back, let's say you got 2 girls, you want a boy, I put back the boy, but I will not kill the remaining. I will keep them and I will ask you whether you want to deliver some more or not. Okay, we don't do sex selection. I don't do sex selection, but I can do PGT to let you have put back the child that you want first.
Thank you for that. Next question I'll answer so that we leave another four for you. If the patient suffered 7 miscarriages and was said to have a short cervix, anything we can suggest? I would strongly suggest refer the patient to tertiary care. Already
Yes.
7 miscarriages. This is
Yes.
beyond primary care. So please refer. For Dr. Tam, next question. Letrozole and clomiphene can be used for how many cycles?
Okay, if you read literature, they say clomiphene not more than 6. Okay, because the risk of ovarian cancer is high after that. Letrozole you can use, but generally I will tell you, you want to do time coitus, which is give ovulation drugs, either clomid or letrozole for 3 cycles, doesn't work, then you better move on to IUI for 3 cycles. If 3 cycles doesn't work, there's already 6 cycles, refer for IVF. So just do 3 of timed intercourse, 3 of IUI. Doesn't work, it's time for IVF. That means the problem is huge.
Brilliant. Right. The Hi doctor, if the patient is thin built, BMI around 20, but having irregular menses and ultrasound showed PCO picture, can we still give metformin? Believe you have taken that.
Yes, please. Yes, please. Because basically her endocrine system, she has got a metabolic imbalance in the form of PCO.
Right.
Yes, she will benefit.
The last two questions, Dr. Tam. Um, the first one goes like this. At what age would you advise for egg freezing for a lady who wants to concentrate on career?
As early as possible, because when you come early, I get very good eggs. You come later, I get telur masin.
Okay. Right. And then when to use injectable ovulation induction.
When all else fails, you give her oral at 1 tablet, doesn't work. 2 tablets, doesn't work. 3 tablets, doesn't work. Forget it. Try injectable.
Right. And yep, again, that ends our 5 questions. One of the participants says, thank you so much, Dr. Siva and Dr. Tam, for a very
Thank
informative
you.
session. I think we have to give a huge round of applause for Dr. Tam. Like he said, with the Delphi, buy one, free one. We were supposed to have him till 9 p.m. and he has stayed on here till almost 10 p.m., giving us double the value. So thank you so much, Dr. Tam, for this invaluable session. Um, double the time that you had initially agreed to do, but thank you. Lots of love and emojis going up there for you. Thank you, thank you, thank you. And maybe as I'm going to share the screen about our future programs and the recordings, you might want to tell again about your program which is coming up on the subfertility while I get the sharing screen. Dr. Tam, final
Sure.
words for
Yeah.
tonight.
I would like to thank Dr. Siva and MMA as well as MMA Perlis, yeah. So for giving me this opportunity to share. To me, uh, sharing information is very important, yeah, because we are working for the public. So whatever we do, we are doing for the public. Okay. Then with regards to the upcoming August, yeah, in August, we are having a hybrid course. That means you can attend online or you can attend physically in Klang. Our fertility course called the HRPB H-Star Hybrid Fertility Course 2025. Yeah. So I think if you have problems attending physically, then hybrid is fantastic. Yeah, the same CPD points we give. If I'm not mistaken, we give 16 CPD points, yeah, just for that one conference. Yeah, it's going to happen in August. Watch the Facebook and watch the MMA. I think Dr. Siva can help us blast in the MMA website too.
Can. Thank you so much again, Dr. Tam, for that. And for all these participants, still more than 400 online, Dr. Tam, who are staying on. Um, thank you. And the upcoming event on the 8th of March, you see, we are the Women's Health Committee, and we are putting together on the 8th of March the third episode of Let's Talk About series. It's in conjunction with International Women's Day 2025. So we have already collaborated with with Penang for episode 1, Perlis for episode 2, and now episode 3, just next Saturday, would not the coming Saturday, but 8th of March would be with MMA Selangor branch. Moderating the session is none other than the Selangor branch chairman or chairperson, Dr. Juliet Matthew. And you can see all the eminent speakers there on the 8th of March. The Dean of IMU University, Prof. Jamia Hassan from UITM, as well as the another Dean of School of Medicine from IMU as well. So that's 8 to 9:30 p.m. You would be notified about this via the email blast. And in the daytime, okay, you're listening to this first here. We have not email blasted this yet. Again, in conjunction with MMA Women's, with in conjunction with International Women's Day 2025, we are collaborating with MMA Wilayah Persekutuan. Women's Health Committee and MMA Wilayah Persekutuan are collaborating for a daytime agenda. There will be CPD points as well. This is a physical event at Auditorium Hospital Kuala Lumpur, 8th of March, in conjunction with International Women's Day, right? Stay tuned. You will hear more about it. And as what we did the last time around, I always ask the participants, what is it that you would like to hear from with regards to Women's Health Committee? So please feel free to put that into the Q&A chat box, into the Q&A box as well. And we will make sure to do our best to facilitate, awareness with regards to women's health. Both these episodes have gone on fantastically, thanks to you all. And I hope we can continue learning from one another. So, with that, I would say thank you so much for being a fantastic audience with all the emojis. Thank you for your time and have a very good night. Thank you again, Dr. Tam, and more than 400 participants still here. Thank you. Good night. Stay safe and enjoy the festivities. Good night.
Good night, everyone. Bye bye. Thank you.
Thank you.